Okay, guys, Dr. Phil here again. I'm going to go through the eye dissection relatively quickly, but with that caveat, I have to cut all of those muscles out. All right, so that's the cow eye. Santa's watching you. All right, so I'm going to cut these eye muscles out. I don't know if this is left or right. I could theoretically go back in here. In the back and see if there's cranial nerve 2 right there between my thumbs. You see that? That's cranial nerve 2. That should come out to the optic chiasm. And remember, the lateral fibers are going to stay unilateral. Medial fibers are going to go contralateral. The optic chiasm through the corporal quadrigemini and then to the occipital lobe for sight. But I don't really know. But the cranial nerve 2 should come in at an angle medially, all right, because we kind of know. But like I said, I don't know if this is right eye, this would be superior, and this would be inferior. If it was a left eye, contingent upon how the cranial nerve's coming out, cranial nerve 2 is coming out, I wouldn't know. But I'm going to literally go in and cut all this muscle material away. So remember, you're going to have a superior oblique, inferior oblique, rectus always means straight. You're going to have like a medial rectus, lateral rectus, superior oblique is going to have something to do with that. Trochlear, and just when you're learning the cranial nerves, just kind of have an idea while you're learning them what they generally do, because they could ask you if something is cranial nerve 2 and cranial nerve 1 are pure sensory. One is olfactory, and cranial nerve 2 is for vision. And then I'll show you a model later about how I'll walk you through how light goes through the eye, the procedure, or the structures or anatomical spaces it goes through, and then when it hits the retina, I'll talk to you about the ganglion cells to the bipolar cells to the retina, and how we're really converting that light into different energy and sending it through cranial nerve 2, and then in its path, it has to go all the way to the occipital lobe, so we can have, I should be cutting this while I'm talking. So we'll have some a semblance of vision or what we're seeing. So I'm really not gonna try to be careful, because this looks nothing like an eye, right? So in lab on Saturday, I pulled this out, and everyone said it looks nothing like an eye. So I keep trying not wanting to call you guys kids, but because I was that age too. But to me, students. So if I call you a kid, it's not derogatory. Just from my perspective, you're all young, which is good. All right, so. Just changing tools here. Okay, there's no number 10 really in this kit. So let me resume here. So I'm cutting the muscle, but remember the muscle is going to be attached to the sclera. And if you look, it's very, very fibrous, very, very durable. There's some of that fibrous connective tissue. See how wispy that is? Very cotton-like. See that? So I'm just going to go in and I'm going to just, it can be fascia, it just separates everything. I'm going to go in and just quickly you know, methodically try not to hack myself up here. So if you look, that is definitely muscle tissue. Okay, you can see the fibers in there. All right, good. I'm gonna go around here. I'm going to just, I'm not gonna be super careful. I wanna get the majority of this off. And then I'll go on to clean it up later. But if you look, I'm just literally cutting away as much of that muscle as I can. And once again, we talked about origin and insertion. This is literally going in and inserting on that sclera, which is super durable. It's got some collagen fibers for a lot of durability. And remember too, we want that for structure. So if the human or the cow or bovine or whatever gets hit or whatever, it has, the sclera is very, very durable. It's not gonna rupture the, I don't even, I can see, you guys can see this. I'm just not looking through the camera, so I hope I'm cleaning this up properly in front of you. I hope the camera's getting all this. But yeah, so we want it for structure. We don't want it destroying the anterior chamber with that aqueous humor or that posterior chamber with that vitreous humor. And remember I said in class, please do not hack. When I do a cut through this, a sagittal cut, I'm not gonna hack into it because I don't want that vitreous humor shooting out. It's gonna be very gelatinous. The viscosity is gonna be very, very durable. But if you look now, that looks a lot more like what you would consider to be an eyeball, right? I mean, I could really go in and tweeze this out with tweezers and clean it up, you know, really, really well, but I'm sure you guys are bored of seeing this already, but I just want to clean away. That is cranial nerve 2. That's the optic nerve. That's coming right off the retina. All right, so I'll get that out of the way. So anterior to posterior, we're going to go cornea. When I cut this up, we're going to have the anterior chamber, which is made out of aqueous humor. Aqueous means water. Humors, when you see that, I did the humors back in the day, even before I was born. All the fluids in the body used to be called humors. All right, the eye's not breathing. I'm just putting pressure in there. So cornea, aqueous humor. Then we're going to hit the pupil, which is not a structure. It is an anatomical space. All right, and that is for constriction or dilation, and that is controlled partially by the iris. All right, and we talked about testing cranial nerves, and your eye should dilate in low light conditions. It should constrict during reading or focus. You know, we talked about that accommodation convergence ratio and dilation. And if you do a pen light in one eye, the other one should react equally. All right, so shining a light in the right eye should cause the left to constrict also. Okay, if not, it's called Argyll-Robinson's pupil, I think. I don't remember. It's been a while. But yes, I think so. So anyway, that's, and then, all right, so cornea, aqueous humor, all right, pupil. This is for light going through, all right? The iris is gonna be right there. Then you're gonna see the crystalline lens, all right? And then right behind that, posterior to that, is gonna be that vitreous humor. That's very, very thick. That keeps the globe of the eye in shape and keeps the retina from coming forward, all right? So if somebody is very, very nearsighted, generally that globe is too long, all right? And the light doesn't focus on the retina, all right? So those people, you have to really warn them. If they're walking around or whatever, and they see something like a curtain closing on their eye, that literally is retinal detachment. That is an absolute 100% emergency. You've got to call the ER and get an ophthalmologist to come in off the, you know, I had, I forgot what her name was, Vivian somebody. She literally came in off of the golf course for a patient. It's crazy. Anyway, yeah, that's a immediate surgery, all right? And then when the light hits the retina, it goes to the ganglion cells, to those bipolar cells. Remember we talked about all those those dendrites and neurons and how most of them were multipolar and things like that. But the bipolar are really only in the retina in humans, and there's some, you know, places that say it's in the olfactory. And remember, cranial nerve 1 olfactory regenerates. It's the only one that can regenerate. All right, and then goes to cranial nerve 2, and then know the path. Cranial nerve 2 to the optic chiasm. Once again, lateral fibers stay ipsilateral, medial fibers go contralateral, and then next semester you'll be talking about the anterior pituitary gland, infundibulum, how that crosses over at the optic chiasm. If you have adenoma, all right, so that would be endocrine adenoma of the pituitary gland, it can start compressing cranial nerve 2 at the optic chiasm, and you can start losing parts of your visual field with no signs or symptoms, because once again, your brain is going to fill in that image. You'll have no sense of what's going on. When I open the eye, we'll talk about the chambers, and remember, increased pressure in there, producing too much aqueous humor can be a problem causing glaucoma, and that can cause pressure of the vitreous humor pushing on the retina, causing that. I'll show you the optic disc where the cranial nerve 2 is, and a lot of pressure in there can cause cupping. So I brought in the retinoscope and the otoscope. None of us used that, but if we wanted to, we could have gone in and seen that the retina. Let me cut this. I'm just babbling away. We could have. I'm going to cut this very slowly. We could have looked at the retina and looked at where the optic nerve is. I'm going to go anterior to posterior. I'm going to cut away from myself. All right. We could have looked at that and seen all that. I'm going to cut this very slowly. I don't understand why. All right, so I'm actually through this. You can see that. I'm going to cut right through that. All right, and remember that cornea should be clear. And remember, once again, it's avascular, A meaning no vascularization, so it can be transplanted relatively easily. There's no blood supply, so there's really no rejection. All right, I don't know, in there you can see that is the crystalline lens. And it's anything but crystalline. You got to remember too, all the students were asking me why. This cow eye has been sitting in formalin forever, so it's going to absorb some of that, changing. And you know, cataracts, same thing. The crystalline lens gets very, very dark and opaque. So they go in and they keep the capsule, and they can go in and change the lens inside of it. So I'm going to just go sagittal here for a second. Cornea, all right. Anterior chamber, all right. So this is where the aqueous humor is. The lens sits right behind that. I don't want to. It's attached by the ciliary fibers, right? Okay, remember that lens can go flat. It can get very, very convex, all right, for magnification, just like a magnifying glass. Up until about age 40, then we get presbyopia, inability to do that. People have trouble seeing up close. All right, so this would be the vitreous humor here. I'm going to just kind of move my scalpel through that, and you can see that's really thick. All right, the viscosity is very, very deep. Now, this right here is actually retinal tissue. You can't really see how thin that is, but that's where all of the rods and cones are. Remember, cones, I always think color, center. All right, so the cones in the center, they're there for color. The rods are in the periphery, they're for low light. All right, I'm going to show you the model later, but please realize that your, hope I get this right, cones can only see red, blue, and green, all right? And from those three sensors, right, they can detect any color and any hue. It's absolutely mind-boggling. All right, so the students were asking me, and I told them before, this is the chloride layer, and if you notice, it's very, very dark. That's going to absorb any stray light, right? And if you know, it's hard for you to imagine that. Remember, if you go to have a picture taken, photograph, they always put a black or white cloth behind you to absorb any stray light, or a white one to reflect it back. Okay, so I'm gonna safely assume that that is not cranial nerve 2, so I'm gonna go to this other half. So I clearly did not do a very good sagittal cut. This is sort of a parasagittal cut, but there is, once again, cornea, aqueous humor, the pupil would be there, and once again, that's not a structure, it's an anatomical space. Iris, you know, in humans, that would be the brown, green, hazel, you know, whatever. All right, there is that retinal material. That, you can see how thin that is? You probably can't. But in lab, you'll be able to see it. It's super, super thin. There's that vitreous humor. That's the crystalline lens. Usually sits back there. And then, I don't know where in the heck. Did not do a very good job of cutting this. I don't know where. Oh. That's cranial nerve 2. So it's got to be where it all comes together. In there should be a small area called the optic disc where they all come together. Maybe I'll cut right through it. And that's a blind spot because there's no rods or cones there. All right. And off to the side is going to be the Fovea Centralis, which is where Fovea Centralis is where the majority of the cones are concentrated. That would be the area of most distinct vision. And if you watch someone doing something very, very fine-tuned, they will not look directly at it, they'll look off to the side a little bit. So they were focusing all of that light on the Fovea Centralis. If you watch that. I am going to apologize again for not being able to find the optic disc. But in lab, someone will cut it. That might be it right there. Is that going? Yeah, there it is. Okay, that is. I guess I could hack that apart a little bit. But yeah, that is right there. That's the optic disc. What's left of it? I don't know how in the world I managed to cut right through that. But I did. And that would lead right to cranial nerve 2. All right, I'm going to just grab a model here real quick. Try to keep this under 20 minutes if I can. I'm going to just peel these off real quick. All right, so. This is this little model I got last year. It's just too cute, so I had to get them. All right. So cornea, aqueous humor, there's the pupil, all right, there's the iris, all right. And then remember, right behind this should be the crystalline lens, which will sort of come out, not supposed to. Oh, can't see that. Sorry. All right, crystalline lens. This is going to be the posterior chamber with that vitreous humor in it, which keeps everything shaped. Right? But once again, if you're super nearsighted or myopic, the globe here is too long. All right, so light rays focus before the retina, and that's why they wear those glasses that are thin in the middle, thick on the outside. All right, refocuses that lens on the retina. But the bigger problem is the globe is so long with the vitreous humor that sometimes there's not enough vitreous humor to hold everything in place, and this retina can detach. When you're also looking at the eye, or the eye model, I want you to start thinking about those muscles again. There's going to be two obliques, superior and inferior. There's going to be medial and lateral rectus. Right? Most of these are, some of these, well, no, most of them are doing the ocular motor, cranial nerve 3, and then there's abducens and trochlear, which one very specific muscles in the eye. Right? So you can learn them while you're learning it, memorizing it, figure it out. I'm going to pop this guy over here. Once again, careful, Santa's watching you. All right, so I'm going to pop this up here. So if we were in lab, or if I was at a station, I would say, what eye is this, left or right? You would say, that's not fair, Dr. Phil, and I'd say, yes, it is, because that's the lacrimal gland. We know it's lateral. Tears flow down here, and they go into the canthus, medial canthus, and then they drain into your nasal cavity. If you don't believe me, next time you cry, see if it runs you know, down your, through your nose, whatever. So this is the right eye, because you're facing your patient. All right, so your left is their right. You'll figure it out. All right, so there's the lacrimal gland. Tears are running down that way. So this is right. This is going to be lateral. This is going to be medial. This is going to be superior. Down here is going to be inferior. Cranial nerve 2. All right, there is the insertion of something on the sclera. All right, remember we said insertion always goes towards the origin. So when you're memorizing this, picture the action. If it's going through the trochlea, see that little hoop? Picture the action of what it's going to do. It's going to rotate and bring that eye in. Okay. So I'm going to pop that out there. Anterior. Okay. All right. Remember, this is going to be black. It's going to absorb, and we don't light hitting here. We don't want it flashing back there. We want it to absorb. Okay. The cool thing about this model right here is it just shows you, these are the ganglion cells from the retina, all right? Goes to the bipolar cells, and then it goes to cranial nerve 2. It just kind of shows you that. So when you're looking at this, just look at from the retina back, like what is the order? Because they like to ask that question, right? There's the inside of the eye. Put that crystalline lens back in there, more or less. Pop this back in there. So just when you get to lab, you probably won't have me, but whatever. Just kind of orientate yourself. Or when you get to any lab practical, look at whatever it is. Don't panic. Take a deep breath in. Look at where it's pinned and see, you know, what. Orientate yourself. That's the best advice I can give you. All right, so 22 minutes. I could have babbled longer, but there you go.